que retumba, zumba.
La luna, mientras siga escuchando tu voz entre las olas, entre la espuma, mientras tenga que cambiar la radio de estación porque cada canción me hable de ti, de ti, de ti. Tu voz entre las olas, entre la espuma, mientras tenga que cambiar la radio de estación porque cada canción me hable de ti, de ti, de ti. Mientras siga viendo tu cara en la cara de la luna, mientras siga escuchando tu voz entre las olas, entre la espuma, mientras tenga que cambiar la radio de estación porque cada canción me hable de ti, de ti, de ti. Mientras siga viendo tu cara en la cara de la luna, mientras siga escuchando tu voz entre las olas, entre la espuma, mientras tenga que cambiar la radio de estación porque cada canción me hable de ti, de ti, de ti. Mientras siga viendo tu cara en la cara de la luna, mientras siga escuchando tu voz entre las olas, entre la espuma, mientras tenga que cambiar la radio de estación porque cada canción me hable de ti, de ti, de ti.
Santander, un paraíso abrazado por la majestuosidad del cañón del Chicamocha. Cuna de la libertad de América, corazón de Colombia y orgullo de miles de santanderianos soñadores y trabajadores que enaltecen la grandeza de nuestro departamento. Aquí, hace 6 años nació Acome Santander, una organización de estudiantes de medicina de la UIS UNAV y UDES que juntos trabajan por dejar huella y construir un país mejor.
En Acome Santander formamos líderes que luchen por un bien común.
En Acome Santander llegamos a todos los rincones de Colombia, llevando un mensaje de esperanza y bienestar.
En Acome Santander nos caracteriza la alegría y el deseo de triunfar como equipo.
En Acome Santander nos representa la unión y el trabajo en equipo.
En Acome Santander promovemos la salud y el deporte.
En Acome Santander repartimos sonrisas y dejamos huella en la población.
En Acome Santander somos parte de la aventura de nuestro departamento.
En Acome Santander nos une el respeto, la empatía y las ganas de crecer juntos.
En Acome Santander nos conectamos con el medio ambiente para preservar la vida.
En Acome Santander somos una familia que permanece unida, sin importar el tiempo ni la distancia.
En Acome Santander luchamos por nuestros derechos y por un sistema de salud digno para todos los colombianos.
En Acome Santander innovamos y le abrimos un espacio a la academia y a la investigación.
En Acome Santander enseñamos y aprendemos juntos.
En Acome Santander levantamos la voz por aquellos que no tienen la oportunidad de hacerlo.
En Acome Santander somos médicos más allá de los consultorios.
Acome Santander, sé parte del cambio.
Acome Capítulo Santander se siente afortunado de contar con más de 400 miembros que con orgullo hacen parte de la gran familia de Corazón Azul. Nos brinda alegría hacer parte de la formación de médicos cuya labor va más allá de los consultorios. No es suficiente con ser buen médico, sino excelentes personas. Desde cada corazón henchido de orgullo en este capítulo, deseamos feliz cumpleaños a la Asociación Colombiana Médica Estudiantil.
Good evening everyone and welcome to the first Acome and LAUGHH Foundation Academy updates. My name is Dayana Workes. I am a general practitioner from Colombia. I've been part of LAUGHH Medical Mission for 4 years and I am an alumni member of Acome. I will be joining you as your host tonight. First of all, I want to mention our patrons that are making this incredible night possible. Johns Hopkins University, FELSOSEM, Grupo CTO, Cardio EKG, Kaplan Medical, Editorial Médica Panamericana, El Savior, Student Network Organization, Congreso de Expedientes Médicos, the American Medical Student Association Intermetro Puerto Rico, and Go Asesores. Thank you so much for supporting the globalization of medicine in Colombia, Latin America, and around the world. We would like to remind you the steps to obtain certification. You must be registered. If not yet, the registration form is in the description box. Then, at the end of every day, our team will enable the attendance form that is going to be open for an hour. It includes a keyword that will be displayed on the screen during the conferences. Finally, you must have attended at least 7 out of 9 days to get your certificate. And that's it.
Muchas dudas sobre el MIR, las despejamos en menos de un minuto. Es una convocatoria anual oficial para acceder a la formación especializada en España. Hasta el momento se ha realizado el último fin de semana de enero, pero con el COVID...
¿Quién sabe si lo atrasarán o no? Por ahora no hay más información.
Consta de 175 preguntas con 4 opciones de respuesta, siendo una única la verdadera. La mayoría casos clínicos y algunas de ellas asociadas a imágenes. Si acierto, tengo un punto. Si fallo, me quitan un tercio. Y si la dejo en blanco, ni me suma ni me resta. Eso me va a dar el 90% de una nota final. El otro 10% lo aportas con tu expediente académico. Requisitos. Inscribirte. Normalmente lo haces en el mes de septiembre. Y tener el título de medicina homologado. Dicho trámite demora más de 12 meses. Así que, si tú metes el MIR, ¿a qué estás esperando? Ah, y se me olvidaba, mientras que te formas como residente vas a recibir un pago mensual por ello. Pero eso ya para el siguiente vídeo de menos de un minuto.
Now, please welcome Dr. Laura Cappelli with her conference titled Evaluating Adults with Joint Pain. Dr. Laura Cappelli is an assistant professor of medicine at the Johns Hopkins University School of Medicine, Division of Rheumatology, and a faculty member of the Johns Hopkins Arthritis Center. She earned her medical degrees from Johns Hopkins. She completed her residency in internal medicine and fellowship in rheumatology at the Johns Hopkins Hospital. Dr. Cappelli earned a Master in Health Sciences degree in clinical investigation at the Johns Hopkins Bloomberg School of Public Health. Her primary research focus is rheumatologic adverse effects of cancer immunotherapy, including the clinical characteristics, epidemiology, impact on patients, and biological mechanism of these adverse events. Dr. Cappelli co-chairs the immune-related toxicity team at Johns Hopkins. In addition, she studies rheumatoid arthritis, focusing on patients with seronegative disease and the use of the autoantibodies as biomarkers. Thank you, Dr. Cappelli.
Thank you and good evening. It's a pleasure to be here from Baltimore. We just had a storm, but now we are in the clear for this talk. So are people able to see my slides yet? There we go. Thank you. So we will get started with something that I hope will be very useful for everyone, which is how to best evaluate adults who are coming into the clinic or the hospital complaining of joint pain, which is a very common complaint that we all have to deal with. And not only might it help us in treating our patients, but also our family members, right, when they come with those questions about aches and pains. So we will get started here. Put on the slideshow mode. So I hope that by the end of the lecture today that you all will be able to characterize joint pain by the duration, the type of joints that are involved, and the number of joints that are involved. And really being able to nail down these factors helps you go down the right path for figuring out why the patient has joint pain. We'll also want to be able to distinguish between inflammatory and non-inflammatory joint pain because those send you down different differential diagnoses. And finally, we will talk about something near and dear to my heart, inflammatory arthritis. And we'll talk about how you might determine different types of inflammatory arthritis by findings of the history and the physical exam. These are my disclosures. So throughout this lecture, I'm going to be using this as a jumping off point for different scenarios. So let's imagine that you have a patient who's walking into clinic, and he's a 65-year-old man with minimal past medical history. He's got a history of high blood pressure, and he tells you he's having knee and toe pain. So the question is, what do you ask him? Where do you go from here? So there are several features that you want to make sure that you're asking patients who are coming into the clinic with complaining of joint pain. First is the duration of the symptoms. And we'll see later on in the talk that 6 weeks duration is kind of an important cutoff point for differentiating acute versus chronic causes of joint pain. You want to know what the person has been doing leading up to this joint pain. Did they have any preceding trauma or any change in activity? Are they doing, in particular, repetitive motions or high impact sports? So these are all important things to ask. You want to ask what else is coming along with the joint pain. Are the joints stiff? Are they looking erythematous or red? Are the joints feeling warm? Are they looking swollen? Are the areas around the joints any of these things? So these are all important questions to ask the patient. You want to narrow down the location of the symptom, how many joints are involved, the size of the joints involved. Is it small joints like those of the fingers or the wrist, or larger joints like the hip or the shoulder? And then the specific joints that are involved, such as the knee or the metacarpophalangeal joint, for example, might lead you down to a particular diagnosis. You also want to figure out if this is an episodic or more persistent process. Is this a one-time process? Is this recurring in episodes, or has this been going on for some time? As we always do with pain, it's helpful to know what are the aggravating and alleviating factors of the pain. And then the associated symptoms outside of the joint: rash, fatigue, shortness of breath, chest pain. Those sorts of things can be helpful in figuring out what's going on. And I said we're talking about joint pain, but often the patient might localize pain to a joint that isn't actually articular, that isn't actually coming from the joint. Pain that is truly articular is typically deep or diffuse pain throughout the joint, and patients will have a limited range on both active and passive movement. They'll often have swelling or some kind of deformity of the joint. And if you contrast that to non-articular joint pain, when you examine the patient, they might have pain on active motion, so if they try to move the joint, but not on passive range of motion. And so, for example, you can imagine if somebody had some tendinitis or inflammation of the tendon, that when they went to move their joint and flex their muscle and move their tendon, that would be painful. But if the examiner is moving the joint, that tends to not be as painful as the patient moving the joint themselves. So you really want to make sure that the pain they're describing as joint pain is actually coming from the joint. Because there are other non-articular conditions that you can think about if somebody's having pain in a certain part of one of their limbs. Depending on the history and their predisposing factors, you might think of trauma and a fracture to the bone giving them pain nearby a joint. Bursitis is also another condition that can be confused with arthritis or articular pain. Similarly, tendinitis or myositis fasciitis are other things you want to think about if the pain is not localized to the joint. But for the rest of this, the purpose of this lecture, we're going to assume that when the patient said joint pain, the pain is actually coming from something that's going on in the joint or joints. Okay, so we have somebody who has pain in the joint or in the joints, plural. So how do we go about thinking of things? And there's not one right way to work through all the possibilities. I'm going to give you one strategy here, but there are certainly other ways to go through an algorithm of evaluating joint pain. But for me, I think it's helpful to ask whether the pain is acute or chronic. And the cutoff we typically use is 6 weeks. So if the pain's gone on for less than 6 weeks, it's acute. More than 6 weeks, it's chronic. And that cutoff point comes from a lot of epidemiologic studies looking at early inflammatory arthritis or early rheumatoid arthritis, where there's really an inflection point when patients are having symptoms longer than 6 weeks. Their odds go up significantly that they're going to have a chronic process. So we'll go and talk about acute joint pain or acute arthritis first. So if you have somebody with acute arthritis, it can be helpful to think about how many joints are involved. Does the patient have a monoarthritis, meaning one joint is affected, or an oligoarthritis, up to 3 joints being affected? Or is this a polyarthritis with 4 or more joints affected? So there's a variety of things that can cause a monoarthritis or an oligoarthritis in the acute setting. Septic arthritis, Lyme arthritis in terms of infection, gout and pseudogout, crystalline diseases, a hemarthrosis where someone bleeds into the joint. This is particularly common in people who have coagulopathies, having trauma to the joint, having a reactive arthritis after an infection, particularly GI or GU, rheumatic fever. These are all sorts of things that will give you a monoarthritis or an oligoarthritis. And a polyarthritis, where there are more joints involved, is a smaller differential in the acute setting. Viral arthritis can definitely do that, or you could have an initial presentation of what ends up being a chronic arthritis. So sometimes you have to follow people over time to really determine what's going on. But I think the most important thing to remember is that when you have somebody who has an acute monoarthritis, so it has lasted less than 6 weeks and affecting one joint, and particularly if the joint is very swollen, erythematous, an angry looking joint, as we like to say, you need to be on the lookout for things like septic arthritis or traumatic conditions, something like a hemarthrosis. And those are your red flag conditions that you really want to rule out. So definitely be on the lookout, particularly for septic arthritis. You don't want to miss that if the patient is coming in with an acute monoarthritis. So let's go back to our patient, the 65-year-old gentleman with the knee and the toe pain. So what if, when we started to interview him further, he said that he had a first episode of pain a year ago where his right great toe swelled and it was red and painful. And since then, he's been having episodes every 2 to 3 months of swelling in his toe or in his knee. And when he has these episodes, the pain is severe, even light touch can aggravate him. The episodes typically last less than a week and then will resolve in the interim, and he'll have periods in between the episodes where he is feeling fine. So we would call this an episodic inflammatory arthritis. And we're going to talk a little bit later about what features make it inflammatory that you're looking for on exam and by history. But when you're thinking of episodic inflammatory arthritis, the most common diagnosis that you'll see is gout, which is caused by uric acid crystals in the joint, causing inflammation. Also, you need to think about pseudogout, which is caused by a different kind of crystal, calcium pyrophosphate crystal. And less commonly, arthritis due to Lyme disease can cause this. And I actually meant to look this up, and I ran out of time, but I'm not sure if Lyme disease is endemic to Colombia or not. But where I live in Maryland, we do have the ticks that carry Lyme disease. And so Lyme arthritis is something that we see in people who have been previously infected with Lyme and not treated with antibiotics. But that totally depends on where your location is and whether you have Lyme disease at your community. So to talk a little bit about crystalline arthritis, so gout, as I said, will probably be the most common thing that you see. It's caused by too many uric acid crystals in the joints, and the crystals set off inflammation. They activate a part of your innate immune system through the inflammasome, which leads to a ton of swelling, redness, pain. If you look back on old paintings of gout patients, they will show little devils or other creatures nibbling on people's toes because it can be so painful. And the uric acid crystals, besides depositing in the joint, can actually deposit elsewhere in the body, such as in the ear, which is the middle picture you're seeing there, are some tophi or collections of uric acid in the ear. And then the picture that you're seeing of the finger, that's a tophus, a collection of uric acid crystals near the joint. So to diagnose gout, we typically try to aspirate fluid from the joint and then look at the fluid under a polarizing light microscope. And the crystals are blue when they are perpendicular to the light in panel A, and they're yellow when they're parallel to the light and needle-shaped. And so that's how you know you're looking at a gout crystal under the microscope. And if you're lucky, you can even see neutrophils engulfing the crystals in the fluid that you're aspirating from the joint. So another main form of episodic inflammatory arthritis is pseudogout, which is caused by calcium pyrophosphate crystals. And you can see in the panel to the right that the crystals are not needle-shaped, they're a bit more rhomboid-shaped, and they are blue when they're parallel to the polarizer and yellow when they're perpendicular. And as in gout, the crystals can also deposit in other parts of the body. In particular, in pseudogout, they can deposit in the cartilage. So you see the knee x-ray, and between the tibia and the femur in the space, in the cartilage space, you'll see a white linear density, and that is chondrocalcinosis, or the deposition of calcium pyrophosphate crystals in the cartilage. So that is pseudogout, and that pseudogout is more common in women, and in particular, people over 60, people with osteoarthritis and some other conditions. So we talked a little bit about acute joint pain, but what if the patient came to you and said the pain has actually been lasting longer than 6 weeks, been going on months or maybe even years? So we would call this chronic articular pain. And an important question to ask in someone who has chronic articular pain is whether or not there's inflammation present in the joint. And so if there is inflammation present in the joints, we call that a chronic inflammatory arthritis. And if there is not, a chronic non-inflammatory arthritis. So how do we tell if the joint pain is inflammatory or not? So we talked about this a little bit already, but we can't go over it too many times. It's an important concept. So some associated features with inflammatory joint pain are, as you said, the joint being erythematous, being warm, being swollen. Patients may complain of morning stiffness, that they feel like when they get up in the morning, it's hard to move their joints. And once they take a hot shower or stretch, they start to feel a little bit better. Or they might have stiffness after sitting for a long time or being at rest during the day. They might feel stiff. And as I said, those symptoms of stiffness might improve with movement or heat. And patients with a chronic inflammatory systemic symptom also give you a clue that there's inflammation going on. And so patients might report fatigue or weight loss, or extra-articular manifestations of a systemic disease such as rash or pleuritic chest pain or other features. So those are the sorts of things that can help you, in addition to your physical exam, figure out whether the joint pain is inflammatory or non-inflammatory. So going back to our patient, our 65-year-old gentleman with the knee and the toe pain, when you start talking to him, he said, yeah, my toe hurts, but my knee pain is the main issue. And my knee pain is worse in my right knee than the left knee. And you know what, doc, I feel pretty good in the morning, but it's worse when I use it. It's worse when I'm climbing stairs. And if I rest and relax, sit down, my knee pain will feel better. And he sometimes feels that his right knee is cracking when he flexes it. So we probably all have encountered patients or maybe even our relatives complaining of creaking and cracking in their knees. And often that is a symptom of osteoarthritis. And osteoarthritis is the most common cause of non-inflammatory chronic arthritis. And it can affect almost any joint in the body, but the most common joints affected are the knees, the hips, the DIPs, which is the distal interphalangeal joints, and the first carpal metacarpal joint, or the base of the thumb, as the patient will often describe it. So those are some of the joints that are commonly involved in osteoarthritis. And getting radiographs, x-rays is very helpful in evaluating osteoarthritis. So you'll see on the left, there are two x-rays of a knee. And they're actually x-rays of the same knee, but the panel on the far left is not weight-bearing, and the panel on the to the right of that is weight-bearing. So you can see that the joint space really narrows, and the osteoarthritis is worsened when the patient is bearing weight, it's standing on that knee, and you can see why they might have more symptoms as a result. And in the other picture, the other radiograph, you can see out at the distal interphalangeal joint, so the furthest out there on the fingers, there are some overlying bony edges at the DIPs that are typical of osteoarthritis at the DIPs. And the joint spaces are narrowed both at the DIPs and the PIPs. The other joints, the MCPs, the metacarpal phalangeal joints, are not as affected. So those are some typical radiographs in osteoarthritis. So besides osteoarthritis, there are other things that give you non-inflammatory chronic joint pain. So Charcot arthropathy, which can happen as a result of a variety of nerve problems. Osteonecrosis, otherwise known as avascular necrosis, which we see most commonly here in Baltimore in patients with sickle cell disease, but you can also see it in patients with chronic alcohol use and in patients with lupus, or patients who have been treated with corticosteroids for other problems. So that is definitely something to keep on your radar for a cause of non-inflammatory joint pain. Hemochromatosis can also give you a non-inflammatory arthropathy joint pain. So going back to our patient, our 65-year-old gentleman, what if he said instead, both of my knees hurt, and it's not my toes, but where my toes attach to my feet that really hurt. The symptoms have been going on for at least 6 months. I feel awful in the morning when I get out of bed, and my feet are sore and stiff when I try to step down. It feels like I'm stepping on marbles, and it takes me 2 hours to feel good in the morning. The joints look bigger to me, they look swollen, and I'm just not feeling very good. So this is a little bit different flavor than the last patient, and this would be somebody who's describing a chronic inflammatory arthritis. And this is what I, as a rheumatologist, see on a day-to-day basis. So I see patients with all of these conditions regularly for evaluation in clinic, and it's really great to be able to take care of these patients and help improve their quality of life and improve their function. So there are a wide variety of conditions that cause chronic inflammatory arthritis. And we won't be able to talk about every single one in this shorter period of time, but we will talk about some. So rheumatoid arthritis is the most common. There's also psoriatic arthritis, ankylosing spondylitis, and other forms of spondyloarthritis, like the arthritis that can come with inflammatory bowel disease, Crohn's and ulcerative colitis. Systemic lupus erythematosus is an important thing to not miss, given all of the other problems it can cause besides arthritis. And then there are a host of other autoimmune diseases like Sjogren's syndrome, myositis, vasculitis, scleroderma, which can cause chronic inflammatory arthritis. But since our time is limited today, we're just going to focus on these first four and how to differentiate the four of them. So going back to our history, which is key for figuring out what kind of arthritis the patient has, how do we differentiate between these kinds of inflammatory arthritis by the history. So how many joints involved is important, and which joints are involved. Is the arthritis symmetric or is it asymmetric? Is there axial involvement, which means is there involvement of the spine, either the neck, the lower back, the sacroiliac joints? And what are the associated non-joint features of the arthritis? And so one way that is suggested that you can kind of go through all of these features to figure out what is causing the arthritis is shown here, which is from the Bible, if you will, of internal medicine, Harrison's textbook of internal medicine. And so they're suggesting that if you have a chronic inflammatory arthritis, first you can look at how many joints are involved, and if they're greater than 3 and you have a polyarthritis, you can look at whether it's symmetric or not. If it's not symmetric, you can consider psoriatic arthritis or enteropathic arthritis, which is associated with inflammatory bowel disease. If it is symmetric, you can ask if specific joints are involved, the proximal interphalangeal joints, the metacarpal phalangeal joints, and the metatarsal phalangeal joints. If those are involved, those are all very typical of rheumatoid arthritis. If not, you can consider other causes of chronic inflammatory arthritis. And so again, there's not one right way to work through this differential diagnosis, but this is one way that you can think about it. So we'll start by talking about rheumatoid arthritis. And rheumatoid arthritis is the most common cause of a chronic inflammatory arthritis. And it's a systemic autoimmune disease that's primarily involved in the joints. And though it's primarily involved in the joints, we can't forget the fact that it is a systemic disease and there's a wide variety of other things that can be affected. The prevalence is anywhere from 0.5 to 1%, depending on the study. Patients are most commonly diagnosed between the ages of 35 and 60. And it's more common in women by about 2 to 4 times as in men, which is typical of many autoimmune diseases. And as we learned from the previous algorithm, the metacarpal phalangeal joints, the proximal interphalangeal joints, and the metatarsal phalangeal joints of the foot are commonly involved, but pretty much almost any joint in the body can be. Interestingly, the DIP joints are not typically involved in RA, which is one way to help differentiate it from things like psoriatic arthritis or even from osteoarthritis. And about 75% of patients have positivity for rheumatoid factor or anti-CCP antibodies in the blood. So when you examine someone with rheumatoid arthritis, you really are using your hand, you're looking at the patient while you're examining them. So you're trying to figure out, are the joints tender when you are pressing on them and moving them? Is there swelling? Is that in the joint itself, synovitis, or in the tendon sheath, which we call tenosynovitis? Are there joint deformities? Are the joints not in alignment? Are they subluxed? And if there are joint deformities, are these reducible or are they not reducible? Are they fixed? And you want to always, even if you're focused on the joints, to look at the whole patient. So you want to look at their eyes. Do they have any evidence of inflammation of the sclera or scleritis? In their skin, do they have rheumatoid nodules? Are there any evidence of vasculitis? Patients with RA can get immune-mediated dry eyes and dry mouth, which we call Zika symptoms. They can get interstitial lung disease. So all of these can provide a clue to the underlying cause of the arthritis. And it might not always be obvious when the patient is first presenting, particularly if they haven't had symptoms for very long. So you see on the left that there is a swollen PIP, but it's very subtle where the light blue arrow is. And so you hope that patients are coming in at that point when their arthritis is still very treatable and they don't have permanent damage. But as time goes on, if they're untreated, you can see in the middle panel that there's a lot of swelling in all the PIP joints. The PIP joints are a little bit flexed from the swelling. The MCP joints are a little swollen also. And then in the final, this is a person who's had long-standing untreated RA, where their carpal bones are totally subluxed. They have ulnar deviation. Their MCP joints are deviating toward the ulnar side. And so we hope to prevent patients from getting these deformities. And these are just some other pictures of certain deformities that patients can get, like a more dramatic example of ulnar deviation, of subluxation, where the joints are no longer in proper alignment and one shifts over the other, which can happen with untreated inflammatory arthritis. And these cock-up deformities in the toes, which can happen with some subluxation at the MTPs, which cause the toes to move upward like that. And as I said, looking outside of the joints is important also. There's a very dramatic example of rheumatoid nodules by the elbow in the left panel, and an example of vasculitis causing necrosis of the fingertip, and scleritis, where you see the thinning of the sclera due to inflammation, which gives it that blue look and the redness around there. So that would be pretty severe scleritis if you saw that much of the eye affected. So there are other things to think about in a patient with chronic inflammatory arthritis besides simply rheumatoid arthritis. And another thing that we commonly see is psoriatic arthritis. And psoriatic arthritis is an inflammatory musculoskeletal disease that's associated with psoriasis of the skin. And its prevalence is about 1 to 2 per 1,000. So it's definitely less common than rheumatoid arthritis, but still something you will encounter. And about 20 to 30% of patients with psoriasis will ultimately develop psoriatic arthritis. So you definitely need to have a high index of suspicion if the patient already has a known diagnosis of psoriasis and is coming with joint pain, that psoriatic arthritis might be going on. For most patients, the skin involvement of the psoriasis precedes the arthritis by about 7 to 8 years. That's not true for 100% of the patients, but it's true for most. And psoriatic arthritis can include arthritis, inflammation of the joints. It can include enthesitis, which is inflammation at the tendon insertion sites. Dactylitis, which is inflammation of a whole digit along the tendon sheath, what's sometimes referred to as a sausage digit, a sausage toe or sausage finger, and axial inflammation, so inflammation of the sacroiliac joints or the spine. And when you're examining somebody where you're suspicious for psoriatic arthritis, you want to, again, do a good joint exam, but also be looking for dactylitis, and enthesitis. The Achilles tendons in particular are a good place to look for enthesitis, but also the elbows, and looking for joint deformities. And you're going to be looking carefully in all of your patients who have inflammatory arthritis for any psoriatic skin lesions, any psoriatic plaques with scale on them, any pustules, the flexor surfaces of the arms and of the legs are common, the ears and the scalp. I've made the diagnosis of psoriatic arthritis in somebody who's just had scalp psoriasis. So very important to look at all of the skin. And people with psoriatic arthritis and with psoriasis can get nail changes. So these nail changes can sometimes be a clue as to the cause of the arthritis. And so you see here some examples of a few of these things. There's an elbow with a plaque of psoriasis, and you see that there's erythematous plaque with a kind of silvery scale over it, which is typical of psoriasis. The middle panel shows a toe with dactylitis. So you see that middle toe is enlarged, the entire toe, and it's erythematous. Not a happy looking toe. So that's an example of dactylitis. And then you can see nail disease in the far panel. And people with nail disease can have involvement of the distal phalanx and the DIP of their arthritis. And there's an erosion in the fourth DIP there that you see on the radiograph. So the nail changes, there are several, but in particular, you're looking for nails that are getting thick or hyperkeratotic, nails that are lifting up from the nail bed, which we call onycholysis. Sometimes nails have splinter hemorrhages or have an oil drop dyschromia. So there are a variety of nail changes that you can see with psoriatic arthritis that can be helpful. So moving on to axial spondyloarthritis. So just a word about terminology. Axial spondyloarthritis is a bigger category that includes what we classically think of as ankylosing spondylitis. And when we say axial spondyloarthritis, we're talking about having inflammatory arthritis of the spine, so either sacroiliitis or spondylitis. And this can be with or without peripheral joint involvement. Most of these patients will present by age 45, and it's more common in men than in women. So that is not as common in autoimmune disease. As I said before, many autoimmune diseases have a female predominance. And in addition to the inflammation in the spine, they might have inflammation in their tendon insertions. They might have dactylitis. They can get eye inflammation, but different than in rheumatoid arthritis, they typically get uveitis rather than scleritis. They can have psoriasis, inflammatory bowel disease, and HLA-B27 is common on laboratory testing. So when you do a physical exam and you're trying to assess the spine, you'll often find limited range of motion in the spine, particularly in patients who've been affected for a while. And this can affect the lumbar spine, the cervical spine. It can affect how the patient's chest can expand depending on what joints are involved. And so there's a variety of maneuvers that you can do to assess that. Patients might have tenderness over their spine or their joints. They might have peripheral joint swelling, dactylitis, enthesitis. And there's overlap with psoriatic arthritis, so looking for psoriatic lesions on exam or eye inflammation. So the top left panel, you can see that in the left heel, there's a lot of inflammation around where the Achilles inserts, and you can't make it out well like you can on the right side. The Achilles is swollen there, and so that's an example of enthesitis. In the panel under that, you see somebody who's had long-standing effects on the spine, and his spine, he's having his spine is fused, and he's unable to reach his head back to the wall, and so you would measure the distance from the wall to categorize the degree of his impairment in cervical extension. And one thing we do in the right panel to assess how mobile the lumbar spine is something called a modified Schober's test, where you find the dimples of Venus, you put marks 10 centimeters above and 5 centimeters below, so for a total of 15 centimeters, and you have them bend forward, and this should expand at least 5 or 6 centimeters when the patient bends forward, and if not, that can be an indication of limited mobility of the lumbar spine. So finally, another thing I want you to consider as a cause of chronic inflammatory arthritis is systemic lupus erythematosus, or we'll just say lupus, or SLE, which is an inflammatory disease that can affect almost any organ system. The prevalence ranges depending on the study, but anywhere from 20 to 150 cases per 100,000 people. And there is a vast predominance in women, up to a 9-to-1 ratio of women to men having lupus. And the majority will present from their 20s to age 50. And most have a positive ANA or anti-nuclear antibody or other antibodies that you'll find on laboratory testing. So when you do the examination for lupus, rashes are very common. There's a variety of rashes. I'll show you a few on the next slide. Joint swelling and tenderness can be seen. Patients can have a true inflammatory arthritis that can look similar to rheumatoid arthritis, but they can also have something called Jacquard's arthropathy, which is a non-erosive arthritis that can cause deformities that are reducible that you can put back into place on physical exam. Patients may complain of oral and nasal ulcers. They may have hair loss or alopecia. Patients can get inflammation around the pericardium, pericarditis, or pleuritis. They can get inflammation in their kidneys, nephritis, although there's not usually much evidence of that on the examination. So lots of pictures for lupus here. You'll see in the top left panel is an example of Jacquard's arthropathy. And you see on the radio that the patient is very ulnar deviated. They also have hyperextension at the PIPs and flexion at the DIPs. And when you look at their x-rays, though, there's no erosive disease there. So it's a non-erosive process. Below that is a classic example of a malar rash in lupus, so an inflammatory rash, also called a butterfly rash, which you can see in acute cutaneous lupus. Going to the right on the top, there is some significant alopecia. In the bottom panel, you'll see some finger ulcers, and then there is a picture of extensive discoid lupus, which is also called chronic cutaneous lupus, which can be very disfiguring and typically leaves extensive scarring. So this is just the tip of the iceberg with lupus, because there's a lot of interesting things to see on examination, but some things to keep in mind. So your history and physical are the most important, and they'll get you far. But to finish the diagnosis for chronic inflammatory arthritis, you need to have some laboratory testing and some imaging. And we typically, if we have a patient where we're trying to figure out what kind of inflammatory arthritis they have, we'll check a rheumatoid factor and anti-CCP antibodies, check for anti-nuclear antibodies, maybe an HLA-B27, check markers of inflammation, the ESR and CRP, and we'll sometimes check other tests based on the results or suspicion for specific conditions, such as lupus. And there's a variety of ways to image the joint, and too much to go into in just this lecture, but these are some of the ways that we image the joints. Radiographs are certainly easy and inexpensive, but typically don't show us the soft tissue structures and can lag behind other imaging. MRI is very sensitive but expensive. Musculoskeletal ultrasound is very useful in that it's dynamic. You can see joints in motion with it, tendons in motion, and you can look at multiple areas at the same time. So that can be great. Conventional CT is sometimes used for gout and pseudo-gout. There's a technique called dual energy computed tomography, or DECT, which can actually highlight crystals in the joint. And if you're thinking that somebody has a septic joint or a bone infection, you can do something like a radio-labeled white blood cell scan. So we won't go into detail about those, but there are a variety of ways that we can image the joints. And I would say this as a final point, and it can be applicable to really any area of medicine, that when you've done your history and you've done your physical, any other testing, and you're putting it all together, keep prevalence in mind. You know, common things are going to be things that you see more often. So it's a good idea to have a sense of what's more common and what's less common when you're trying to figure out what the patient has. And here is another algorithm from Harrison's Internal Medicine, thinking about what's common at the top to what's less common at the bottom, and on the left, dividing it at age 60. So for adults under 60 versus adults over 60. So these are important things to keep in mind. It's much more likely that somebody has osteoarthritis than a septic arthritis, but you don't want to miss the septic arthritis because that can really be an emergency and people can get quite sick. So keep the prevalence in mind, but also keep an open mind to the whole differential diagnosis. And with that, I am going to end the show, and we can take any questions that anyone might have.
Thank you, Dr. Cappelli, for the amazing lecture. It's really amazing to just realize what you're able to do just with physical exam and medical history. So, well, our team is selecting the question, and on behalf of Acome and LAUGHH Foundation, we want to thank our participants. We have almost 1,500 people from all over the world, from Colombia, USA, and a lot of Latin American countries, but also people from Spain, Ghana, Nigeria, Egypt, Sudan, Nepal, India, Burundi, Kazakhstan. They're making an incredible effort with their local time. So thank you, guys. And we're going to start with questions. The first question is, inflammation that comes and goes for long periods would be considered as chronic event, though it is not constant?
Yeah, that's a very good question. So autoimmune diseases are often characterized by periods of flare where the disease is worse, and then periods where it's less evident. So I think it depends on, how long it's gone. Somebody with rheumatoid arthritis, particularly long-standing RA, is unlikely to go a long time without symptoms if they're not on any treatment. But somebody with gout or pseudo-gout, if they're not having a flare, might be relatively asymptomatic. So I think it really depends on the underlying cause. But yes, I think even if somebody's having episodes, and those episodes have been recurring over a long period of time, that's a chronic process.
Thank you. Next one is, good evening. What treatment would you propose as the first line for psoriatic arthritis in a 15-year-old woman without comorbidities?
Wow, I love that question. It's so specific. So I would probably choose methotrexate if there were no comorbidities for somebody who had psoriatic arthritis, because it's got activity for both joint disease and skin disease. And it's relatively inexpensive compared to some other medicines. If they have very mild disease, one could consider sulfasalazine, which is called different things and different. If it's unclear, please ask me to clarify, because some of these medicines have different names in different countries. But yeah, sulfasalazine if it was mild, but for most people, methotrexate.
Thank you. Up to 80% of rheumatoid arthritis patients are HIV positive. What does that mean?
Oh, no, that they're not HIV positive. At least not in the world. So up to 80% of rheumatoid arthritis patients have autoantibodies, either rheumatoid factor or anti-CCP antibodies. Patients with HIV can get, untreated HIV in particular, can get an arthritis that looks like spondyloarthritis. So that is something that you don't see in well-treated HIV, but in untreated HIV you can see. But there's not really a direct link between rheumatoid arthritis and HIV. But people with HIV can get an inflammatory arthritis. I hope that answers that question.
Thank you. Should people with gout stop eating meat for the rest of their lives?
I think everything in moderation. And if they are on a agent like allopurinol or febuxostat to lower their uric acid, they might be able to have some dietary indiscretions now and again. But I think if they keep the portion sizes small and they don't eat it all the time, they don't have to totally abstain. If they're getting recurrent gout attacks, they should be on medicine to lower their uric acid. And then that is adjusted until their uric acid is where you want it to be.
Thank you. The inflammation that lasts for long periods and sometimes is stopped for a short time is chronic. Is it seen more in a specific type of person?
So I think I would consider that chronic. And there's a range of ways that people present with autoimmune diseases. In certain autoimmune diseases, it's unlikely that you're going to go a long time without symptoms, like rheumatoid arthritis, as I said before. But some can flare for a variety of reasons. Some things that we know cause flares are getting an infection, having problems getting your medications and going off your medications. That's an obvious one. Having physical stress or trauma to the joints can then cause a flare. So, and sometimes we don't know. Sometimes we don't know why somebody's been having more or less activity. If somebody with psoriatic arthritis loses a lot of weight, sometimes their psoriatic arthritis improves considerably. So it really depends on the specific disease, what factors influence this.
Why does axial spondyloarthritis usually appears at age 45?
So it usually appears before age 45. So it can happen as early as the 20s. I don't think we have a great understanding of why, but just we have good epidemiology that it does typically appear before age 45. I think also as people get older and you're thinking about back pain, which we didn't really go into in great detail, you start thinking a lot more about degenerative disc disease and arthritis of the spine, facet arthritis, some of those conditions more than inflammatory arthritis. But yes, it's a great question, and if you can figure that out, that'd be good.
If a male patient less than 40 years old and not obese, would there be any specific and prevalent cause for the development of gout?
So some of gout is genetics. It has to do with the transporters that are in your tubules and your kidneys and how well you clear uric acid. So they could have just a genetic predisposition to gout. Besides that, chronic kidney disease. So that the person's not obese, but they could have chronic kidney disease. They could be on medications like HCTZ, hydrochlorothiazide, that increase the propensity to gout. But a lot of gout is genetic and how well your body processes the uric acid.
Well, those were all the questions, Dr. Cappelli. Thank you so much for being here. Thank you so much for the amazing lecture. We really want to have you in some other events. So thank you so much.
Thank you for having me.
Now it's time to continue with the second conference named "It is Not a Tumor, a Practical Approach to Headache in Children and Young Adults." Please welcome Dr. Christopher Giza. Dr. Christopher Giza obtained a Bachelor of Arts in Biochemistry from the Dartmouth College, a medical degree from West Virginia University School of Medicine. He completed his internship at the Hospital of the University of Pennsylvania and his adult neurology residency and child neurology fellowship at UCLA. He also completed a postdoctoral in neurotrauma at the UCLA Brain Injury Research Center. Currently, Dr. Giza is the director of the UCLA Steve Tisch Brain Sport Program and UCLA Easton Clinic for Brain Health, and the medical director for the Traumatic Brain Injury UCLA Operation Med Warrior Care Center. Welcome, Dr. Giza, and thank you so much for being here.
Thank you. It's really a great thing that you're able to put together to provide this education during the time of COVID. I'm going to talk about something that is very common and is really relevant for people in many specialties outside of neurology who are involved in primary care of children and young adults. I'm going to talk about headaches, which is one of the most common symptoms that people can have. And the title of my talk, It's Not a Tumor, is to address the concern that everybody has when they have a headache, that the headache is caused by a brain tumor. I'm going to give you a practical approach to how to evaluate these and what the relative risks of different specific diagnoses are. So let me move on to the next thing. Yep. All right. Okay, so what we're going to learn about today, we're going to learn out how to distinguish clinically between the main types of headaches in pediatric, adolescent, and young adult populations. And by clinically, I mean by the history and the examination, and limiting the use of ancillary testing or only doing the testing when it's necessary. And that goes into part 2, which is what is the appropriate diagnostic workup, and then certainly what's the initial treatment interventions. And for the treatment interventions, I will start with interventions that are best initiated at the level of primary care provider, the family doctor or the pediatric doctor, and then show how that might escalate if you needed a referral to a neurologist, what kind of things the neurologist might be thinking about. So when your patient comes with headaches, what are the things that you need to take into consideration to evaluate what the cause of the headaches might be? I focus on these three things, the temporal pattern of the headache, the acuity of the headache. Are they presenting to you in the emergency department or in the urgent care, or are they coming to clinic and they've had the headache going for some days or maybe even longer? And then, of course, most important is what's the actual description of the headache and the type of the headache. And this can be a little bit challenging in very young children because they may not have as many words to explain what they're feeling, but the description of the headache is always important. Okay. So the first kind of temporal pattern of headache is the one that we worry the most about, maybe, that there's no headache at all, and then all of a sudden there's a really bad new onset headache. Okay. And what is this most likely? Well, we don't know for sure, but one of the things we want to rule out is some type of catastrophic intracranial bleed. On the other hand, it could be the first attack of migraine, and particularly in adolescents, this may be statistically much more common. What about a temporal pattern that looks like this, where there's a sudden increase in the headache, and then it gets better after some time, and then there are maybe days or weeks or months in between with no headache, and then another severe headache and coming and going, an acute, episodic, or recurrent pattern? And that's almost definitely in pediatrics going to be a migraine headache. In young adults or older adults, you may also have tension headache in here, but mostly migraine. What about a headache that is subacute or chronic? So it's not too bad maybe in the beginning, kind of fluctuates a little bit, but slowly getting worse over time. Again, this temporal pattern is worrisome for progressive lesion in the brain, like a tumor. So this would be the pattern that you would need to be careful about. On the other hand, someone who has a chronic headache that may be fluctuating, but over the course of days or weeks is staying relatively the same. Okay, some days are good, some days are bad. That's much more likely to be a tension headache or a chronic daily headache, not due to an intracranial lesion. What about the presentation of the headaches? Well, those who come to the emergency department or urgent care are more likely having a sudden, severe headache, acute new onset headache, or episodic. Patients who are showing up in your regular clinic are more likely at the other end of the spectrum. Their headache is very chronic or maybe very slowly progressive. And so when you look at these different type of patterns and the different areas of presentation, it helps narrow your differential diagnosis to think about what is the most likely kind of headache in this person. Now, when you're getting the history or when you're doing the examination, there are some things we have to separate between the headaches that are worrisome, okay, the rare problem of a mass lesion in the brain or elevated intracranial pressure, from the type of headaches that are very common, like migraine and tension headache. So the signs and symptoms of a headache due to a mass lesion in the brain, so potentially a tumor or some other problem, would be a headache that's persistently unilateral, always in one spot, never moves, okay? Another is if there are neurological exam findings that are focal. Is there weakness on one side of the body? Is there a visual field cut in one part of the body? Did they have a seizure and the seizure would have a focal onset? All of these things make you very concerned about a focal lesion in the brain. Now, focal lesions can cause these symptoms, but don't have to cause pressure, or they can also cause elevated intracranial pressure. The signs and symptoms of headache due to elevated intracranial pressure include persistent nausea or vomiting, including waking up at night with worsening of headache, nausea, or vomiting. In some cases, the mental status is changed. They're either confused or you become lethargic and sleepy. And on physical examination, you will see papilledema, the raised optic disc. You can also have elevated intracranial pressure without a focal lesion, like in hydrocephalus or idiopathic intracranial hypertension. So you can have either of these symptom complexes separately, or you could have them both at the same time. In any case, these are worrisome signs and symptoms. Okay, so here's some headaches for this guy. Oh, all right.
That's some unique kind of talent.
Okay, so what happens with a sudden onset headache? All right, let's talk a little bit about that. Well, like most things in neurology, the diagnosis hinges largely on the history. So having an ability to get a very good history and learning how to take the history from younger children, if you're seeing those kind of patients, is also very important. Again, the things that are important in the history is the temporal pattern that we talked about, right? Those 4 patterns. When was the onset of the headache? You know, was it today? Was it yesterday? Or if it was a patient with more chronic headache, how long have they had the headache? Weeks, months, years? If the headache is recurrent, so it comes and goes, how long does each headache last? Does the headache come and it lasts for 1 hour? Does it last for 6 hours? Does it last for days? And how often is it happening? Is this person having one really bad headache every 6 months, which means then you would do a certain kind of treatment? Or is somebody having a frequent headache multiple times per week is causing a lot of disability? You also want them to describe the nature of the pain. And so I often give kids a few choices, like throbbing or pulsing, like your heartbeat would be one type of pain, a sharp pain like being stabbed, or pressure-like pain, just all over the place, pressure like that. But you can also have the patient tell you in their own words and get a good feel for what the nature of the headache is. You also want to know, are there associated symptoms? When you have the headache, do you have nausea, vomiting, dizziness, visual disturbance, alteration in mental status, confusion? Do you have seizures? Okay, if any of these things are very important in determining what you're thinking about for the diagnosis of the acute headache. On examination, you need a combination of general findings because many headaches are caused by non-neurological problems. They're secondary to something else that's happening in the body. And then you also want a good neurologic examination because some things are primarily neurological. So your vital signs are important. Fever is a very common cause of headache, so you want that. Hypertension can also cause headache, not so much in kids, but often in older people. Your examination of the head is important. You want to look for evidence of sinusitis or mastoid infection. Is there trauma to the head? Do you see any type of hematoma in the scalp? You look at the eyes. Well, the eyes have many important signs for headache, including some of the autonomic signs, like injection of the conjunctiva, tearing or crying, particularly during the headache. You also want to have a good look at the fundus to look for papilledema, which is obviously the thing that would be worrisome for increased intracranial pressure. Neck examination is also important. There can be tenderness, there can be trigger points. In a patient with fever and mental status change, there could be stiffness in the neck, indicating meningeal signs. And of course, your neurological examination is important. If there's any focal findings, like we said, visual field cut, weakness in one part of the body, sensory loss in one part of the body, things like this, those are all extremely important when seeing the person with a new onset acute headache. So you have your history and you have your exam. At this point, you should have a good idea of what the diagnosis is. And so the real question is, if you're going to use diagnostic testing in an acute setting, is really one of two things. Either you already have a clinical suspicion and you need additional testing to confirm it, or you're not so sure, you think something dangerous might be happening and you need additional diagnostic testing to make sure that that dangerous thing is not happening, to rule out something dangerous. Now, what kind of diagnostic testing can you do? Well, if you suspect it to be secondary to a systemic problem like an infection or other than that, maybe labs will be appropriate. What about brain imaging? We'll talk more about this, but if you suspect that there's a bleed in the brain or that there is evidence of trauma, or perhaps there's a mass lesion, signs of a mass lesion or elevated intracranial pressure, then you may need some brain imaging. But in most cases, we'll see actually that's not necessary. If you suspect intracranial infection with fever, change in mental status, neck stiffness, and things like that, you may need a lumbar puncture to rule out intracranial infection. And EEG, in general, for the workup of headaches, EEG is not very specific and generally not indicated, particularly for an acute headache. Now, what about imaging for acute headache? Okay, in most cases, for acute headache, it's not necessary to scan a patient. Okay, particularly if you have a history. So if you did a good history and the history is compatible with migraine without aura, so there's no focal findings, or a history compatible with tension headache. And we'll talk about those specific headaches in just a few minutes. But if you have a history compatible with that and a normal neurologic examination and the fundoscopic examination shows good optic discs, you generally are not going to need to scan those patients. For people with an acute headache who might need imaging, include those with traumatic brain injury, particularly if there was a loss of consciousness, then CT scan is pretty important. If they present and tell you, this is the worst headache of my life, I've never had a headache this bad. If they have signs or symptoms of elevated intracranial pressure, okay, like we talked about, or if they have focal neurological signs. Okay. If you're imaging somebody in the acute phase and you're suspicious for bleed or other catastrophic problem, a non-contrast CT is usually sufficient. If you get a history that the headache has been getting worse gradually and then suddenly got worse and you suspect maybe is a tumor, if you have access to MRI with gadolinium, that's preferred. Or you do the CT scan with contrast if you're looking for tumor. Again, in most cases, you don't need imaging, but there are some times when you have to take a look. So this is a summary of a couple of different studies looking at the presentation of pediatric patients to the emergency department and they're coming to the emergency department with headache, and what are the most common causes of that headache. And what you can see here in the average child is the fever is the most common cause, okay? And this is due to systemic infection, extracranial infection, a recent head injury or concussion, a sinus infection, and migraine are the top four. All of the things that we worry about very dangerous in terms of meningitis, high blood pressure, brain tumor, are all very small percentages. Okay? So most of the things are diagnosable clinically and treatable. Let's talk briefly about those top four things. So fever or some type of infection outside the brain. Okay, so obviously the patients present with fever. You may have to look then for where is the infection? Is it in the ear? Is it in the lungs? You do want to rule out any signs of intracranial infection. They shouldn't have any mental status change. They shouldn't have neck stiffness, things like that. These patients are then treated, with anti-fever medications, pain medications. If you diagnose a bacterial infection, then obviously you'll want to treat with antibiotics. In this case, this is most common in pediatrics to have some kind of viral infection or some other kind of infection. Head trauma is also pretty common. Most of the head trauma that causes headaches is actually milder head trauma. Severe head trauma will cause mental status change. The patient may not complain of headaches because they will be confused or they will be unconscious. But milder head injuries like concussions happening in sport or falling down can often also result in headache. And then so you have to decide based on the clinical presentation whether or not you have a suspicion that this injury was severe enough to have an intracranial bleed. And if it was, then again, you can do imaging. Most cases of post-concussive headaches, actually the injury is so mild that a CT scan is not needed. In that case, then you can just treat with pain medications. It's important to reassure them after this concussive type of brain injury that they can have good recovery. This is a good opportunity to help prevent future injuries, particularly if they participate in a contact sport, to let them know they shouldn't go back to the sport too soon and they have to wait till the symptoms have resolved. The return to play should be gradual, not all of a sudden going back. That will make the headache worse. And you should be aware that they may have some cognitive difficulties during the early time after the concussion. So that may mean that they need some extra help in school for a few days, or maybe even need to stay home from school or have less assignments to help them gradually get back to recover. What about a sinus infection? Again, this is an infection outside the brain, but you need to rule out an intracranial infection. So again, looking for mental status change, neck stiffness, other things. You can rule out the intracranial infection clinically. While you can make the diagnosis of sinusitis clinically based on nasal discharge for a certain number of weeks and fever and other maybe tenderness over the sinuses and things like that, you can use brain CT or X-ray to confirm by finding fluid levels or opacification in the sinuses. Again, you can treat with anti-fever medicines, anti-pain medicines. If the suspicion is bacterial sinusitis, then antibiotics are needed. You need to distinguish that from a viral upper respiratory infection or some allergic problem, which wouldn't need antibiotics. And then migraine is the last of the top four in kids. And this is a child drew this picture describing what their migraine headache was like to them. And you can see it's unilateral, very severe pain around the eye. Again, this is still a clinical diagnosis. We'll go over what the clinical factors are. And if you have typical clinical history and a normal exam, neuroimaging would be unnecessary. The treatment we'll also go over in more detail, but can be summarized in 4 things. Identify if they have any triggers. If they do, try to avoid those. Keep a headache diary. Sometimes that's helpful if somebody has chronic migraines. Treatment to stop the headache. Okay. Most patients with migraine will benefit from this. And then some patients may need preventive therapy if they have repeated or recurrent or very frequent migraines. So let's talk a little bit about migraine now. The most common form of headache in pediatrics, the most common form of primary headache. So if you take away all those systemic things like fever, sinusitis, concussion, then the most common primary headache disorder in kids is migraine. Migraine without aura, which means it occurs without any focal neurologic findings. These are episodic attacks of moderate to severe pain, bilateral or unilateral, okay? And it's often described as throbbing or pulsing. There's a lot of nausea or vomiting, dizziness associated with it. And then usually they will have photophobia and phonophobia. So they are sensitive to bright lights and sensitive to loud noises. The migraine with aura has the same clinical features, but there's also focal neurological symptoms that immediately precede the headache and then subsequently resolve. And sometimes this includes loss of visual field that they can't see on one side. They have numbness on one side. They have weakness on one side. Very commonly, they may have visual obscurations called scotoma. And these are drawings from patients of what they saw in their visual field at the beginning of the migraine, sometimes really preceding when the pain starts, they get these visual symptoms. So migraine with aura, especially if it's the first time they have it, you may still have to do neuroimaging. Migraine without aura, otherwise, and with a normal exam, may not require, and we'll talk about that. Okay, now sometimes it's helpful, especially if somebody has recurrent migraine, is to have them keep a headache diary. Okay? And you have to keep it simple. You don't want to ask the child every hour, do you have a headache? That kind of focus on the symptoms will actually probably lead to more reporting of headache symptoms. But at the end of the day, and somebody who's used to having headaches, you ask them, is there a number? And you can use a number from 0 to 10, with 10 being the most severe. 10 is the worst headache. There might be a headache so bad that would make you cry. 0 means there was no headache that day. And then you can keep track like this over a couple of weeks. And what you can see is, here's somebody who looks like they had, 5 days of headache this week, 5 days of headache this week. Hard to tell if there's much difference, but if you actually add up the numbers and look, and you can see, well, actually, there was a slight improvement on average, particularly toward the end of the second week. And so sometimes if you have a headache diary, it can give you an idea, especially if you started doing some treatment, and maybe the treatment is starting to work. Now, there's a lot of focus on triggers of migraine, and I'll say there are many, many things have been associated with triggering a migraine, but many things have been claimed to trigger migraines that are not related. So for most patients, we try to look and see, is there a pattern? And if there's a consistent pattern, we remove that one item, if it's possible, and see if the migraines get better. Then you can reintroduce that item and see if the migraines come back. If you do that a couple times and it really happens, then that may be something that triggers their migraine and could be avoided. You can't avoid everything, or else the child will have nothing to eat and nothing to do. So you have to be careful about what is identified as a trigger. Some of the more common dietary triggers are things that contain tyramine, which include cheeses and other things like that. Aspartame, which is an artificial sweetener, caffeine or alcohol, not so much obviously in kids, but caffeine, a lot of teenagers drinking coffee products. Nitrates and nitrites, which often occur in processed meats like jerky and hot dogs and bacon and things like that. Monosodium glutamate, which occurs commonly in different seasonings, particularly Asian foods. Citrus fruits in some people will trigger migraine, and chocolate in some people. Not everybody with migraine will have triggers from these things. Most people with migraine will not have a clear trigger. But if you find somebody who is, and you can identify, oh, it's chocolate, or oh, it's monosodium glutamate, then it becomes easier because the person can try to avoid those type of triggers. You can also have medication triggers. Some of the antacids that are commonly given, some of the blood pressure medications, people who use an over-the-counter analgesic or an opiate too frequently can have medication rebound headaches that can cause problems. Not so much in children, but older patients who have cardiovascular problems who take nitrites for coronary artery disease, or sildenafil for erectile dysfunction. These are medications also that can trigger migraine in older patients. And there are many biobehavioral triggers. And again, these are often hard to avoid completely. So it's important to identify if they are there, but you can't typically get away by just completely avoiding them. Instead, you have to do things to mitigate the stress. So certainly psychological things like anxiety or depression, physiological things like hunger, being sick with something else, or not getting enough sleep. There are environmental stimuli, lights and changes in pressure, computer screens, physical exertion, exercise, or things like that. Also potentially head injury, and then travel in motor vehicles. All are potential triggers for migraine. So these are things to ask about, but be careful not to overly restrict people. Now, the first tier of so you've got your headache diary, you've got looking for triggers. The next step is to say, what medicines are you going to use to stop the headache when it occurs? Okay? And the first tier medications for migraine, once you identify that, are actually medicines that are readily available over the counter. Acetaminophen or the non-steroidal anti-inflammatories like ibuprofen have good randomized control trials that show that they work very well in kids, 60 to 70% effective, have little in terms of side effects, and just make sure that they're not taking them every single day with the headache. The second tier medications, and these are probably the first tier for neurologists, but I think for primary care, obviously you want to try the easier ones first. There's a whole bunch of different medicines that are migraine specific. These are typically in the class of triptan drugs, and I've listed them here, along with the way in which they are administered. So an orally disintegrating tablet or nasal spray. Actually, sumatriptan is also available in sub-Q injection, but that obviously is not preferred by most children. So we typically use like a rizatriptan or zomatriptan because they have orally disintegrating tablets. So the tablet just goes in the mouth and it dissolves. Even if you have nausea or vomiting, the tablet is there, not in the stomach. So that's a little more helpful. Most of these medications, at least in the United States, aren't approved for all pediatric ages. Rizatriptan goes down to age 6, zomatriptan, sumatriptan, amitriptan to the early teens. Some of these other ones are actually only approved in young adults, although some practitioners will use them in children. The important thing when you use a triptan is they should try to take it as early into the headache as they can tell. This is a migraine headache, I better take it soon, okay? And you have to be careful about not taking too much. If you take too much of the triptan, you will definitely get a medication rebound headache, okay? The limits are typically 3 or 4 doses per week, or 6 to 10 doses per month. And obviously you have to make some judgment there if the child is 8 years old versus 18 years old, but you want to avoid the overuse headache. There is evidence that sumatriptan in conjunction with naproxen, so combining a triptan with the nonsteroidal, is slightly better than either by themselves. And there are drugs that combine these that are brand name drugs that cost more money, or you can dose the 2 medications individually, side by side. There's another medicine called Midrin, which is a combination medicine of these things. It's not as readily available, but was available in the past. And then if a patient has a lot of nausea or vomiting, you want to use antiemetics to help them. You can, of course, also, I didn't put here, but I should also put probably ondansetron is another possibility. The third tier medications are medications that can work, but are generally not used that often in pediatrics. So the ergotamines, okay, very strong medications, but also have a lot of side effects. Ketorolac, a non-steroidal, but also has a lot of potential side effects on the stomach. And opiates, which actually most people will say that for bad migraines, even bad migraines don't need opiates. You have many other things to use before you get to that, and particularly in children. Now, in a primary care side, you're going to be here at the beginning using these things. Maybe if you're comfortable trying the first triptan. If those things aren't working, or if you're not sure of the diagnosis, that's when you would start to consider referral to a neurologist to do maybe more diagnostic workup or to give advice with the medications when you get to second and third tier. Now, there are migraine variants. A number of well-known variants are more often seen in children and adolescents than in adults. And again, these typically would require referral because they're not so common that a primary care doctor will see a lot of these. But there's a familial hemiplegic migraine. This is really not even kind of a migraine. This is an autosomal dominant genetic disorder that they can have severe headache, confusion, and usually have hemiparesis that can last for several days with gradual recovery. It will look very much like a stroke or a transient ischemic event, but with a headache. So when these patients first present, of course, they will need to be scanned. Ophthalmoplegic migraine, pretty rare. The eye becomes very painful and is unable to move. Headache is on that side. The brainstem or Bickerstaff migraine, which has typical headache like a migraine, but many, many brainstem symptoms: vertigo, double vision, ataxia. Again, all these focal neurologic findings would require imaging before you can make this diagnosis, because you want to rule out something worse. Can you have a migraine in the retina itself? You have visual loss in one eye with a very mild headache on that side, sometimes can be called that. Kids have confusional migraine, again, sometimes triggered after a mild traumatic brain injury, where they have confusion that can last for hours sometimes. Again, in this case, you're probably going to scan them first because it's worrisome enough. It could be something more severe. And there are a few other periodic syndromes: benign paroxysmal vertigo, paroxysmal torticollis, and cyclic vomiting, abdominal migraine. These are things that are more commonly seen in kids. Some of them don't even have a lot of headache with them, but they are thought to be precursor to migraine. Other types of headache that can occur acutely, now don't happen very commonly in kids, but can happen more commonly in young adults or older patients, will be neuralgias. So these are very short, brief, painful, sharp pains. Very common will be occipital nerve, getting pinched in the neck and sending pain radiating over the head. These can be treated. Often you will find point tenderness directly over it, or when you push, you can actually induce pain in the distribution of that nerve. You can use tricyclics, you can use anticonvulsants. Local nerve blocks can also be very effective. Again, not very common in kids, sometimes after concussion, sometimes in young adults or older adults. A cluster headache is another type of very severe headache. It's very rare in kids, so you're not going to see it that often, but not that uncommon in younger adults, and particularly young males. It's very sharp, lancinating pain centered over the eye, one or the other. It's associated with lots of autonomic symptoms, droopy eyelid, the nose is running, the eye is tearing, and these headaches may happen repeatedly over several days or weeks, and then go away for months or years, and then come back again in a cluster. They're very debilitating. These patients generally don't want to lay down in a quiet place. They are quite agitated, can be treated with a number of things, including high flow oxygen, lidocaine sprayed up into the nose to try to get to the sphenopalatine ganglion, or triptans, which are used obviously primarily for migraine. These are very rare in kids, but again, you will see them sometimes in younger middle-aged adults, particularly males. Now, there's that other category of acute headache that is a very small percentage, but there are some worrisome things in there. So these are things to think about if the headache doesn't fit into the big categories: fever, migraine, sinusitis, concussion. So drugs or toxins can cause headache, but they usually cause mental status change, ataxia, may cause seizures. So then obviously you have to look for different things to find this. Intracranial hemorrhage generally, again, will have elevated ICP, focal neurologic signs, mental status change, seizures. Same with hydrocephalus, except you won't have focal findings. Bacterial meningitis we also talked about. So these things are worrisome, not very common, but if you suspect them, obviously you have to do the additional diagnostic tests. Low blood sugar, anemia, dehydration can cause headaches. Idiopathic intracranial hypertension we'll talk about with chronic headaches. Cluster is very rare, post-lumbar puncture. Most of these other things are pretty rare. And psychogenic causes of headache are really a diagnosis of exclusion. You have to try to rule out what the headache is first. The serious diagnoses are a very small percentage, 3.5% to 6% of all acute headache presentations. So most people you see with an acute headache are still going to have something that's very recoverable and very treatable. Okay, so let's talk about chronic headaches. I don't know what it is about these people who want to smash things with their heads. All right. Okay, let's stop. All right. So anyway, so you can imagine there are lots of different ways you can get chronic headaches. How do you evaluate somebody who comes to you who has had multiple headaches over a period of days or weeks? Well, it actually ends up being very similar to the evaluation of an acute headache, but you have a little more time to figure things out. So you still look at the temporal pattern, you look at the onset, duration, and frequency. You want them to describe what the pain is like, and you want to find out if there are associated symptoms. Okay? And that also includes, I will add to this, photophobia and phonophobia, because those are classic symptoms for migraine. You do the same thing with the clinical exam that we talked about before. Blood pressure still important. Look for sinus or mastoid tenderness. Look for papilledema in the eyes. Look for neck problems that could be causing it. And of course, do a good neurologic examination to make sure that there's no focal findings, because this is where you wouldn't want to miss. If there was the rare chance of a tumor, this is where you would find it on your examination or your history. Okay. Now, again, the same thing that holds for the acute headache. The reason why you do additional tests is either you have a diagnosis that you're suspecting and you need to confirm it, or you want to rule out something that is going to be disabling or going to be worse over time. Okay? But you should have an idea of what your diagnosis is after your history and your examination. Okay? Again, you can do laboratory studies to rule out systemic etiologies, anemia, other things like that could present with some blood tests. A brain MRI, if you have the resources for brain MRI in the setting of chronic headache, Brain MRI is usually better, particularly for looking for a mass lesion or a tumor. You can, of course, also do CT scan with contrast. Lumbar puncture, this will be indicated in certain circumstances. If you suspect a focal lesion, then you typically don't want to do a lumbar puncture until you've done the brain MRI, because you don't want to pull pressure out from underneath if there's elevated pressure up here. But if you think there's a chronic brain infection, if you think there's elevated intracranial pressure, like what we call pseudotumor cerebri or idiopathic intracranial hypertension, which has no focal lesion, then at that point, collecting CSF and measuring the pressure is important. And just like with the acute headache, EEG not really indicated for workup of chronic headaches. Now, when do you scan in chronic headaches? Well, very similar to the acute headache, if you have a chronic or recurrent history is compatible with a diagnosis of migraine or tension headache, like we talked about, have those clinical features, and you have a normal neurologic examination and an optic disc that looks normal, then you don't need imaging. If you do have focal findings or something else that makes you worried, and it's a subacute or chronic setting, then MRI is preferred. And again, MRI with contrast if you're thinking about tumor. Now, just like I showed you in the acute headaches, what were the most common causes were fever, concussion, sinusitis, and migraine. In the chronic headache, it's much different and in some ways much easier. Most of the chronic headaches are actually primary headaches, primary neurologic headaches, either migraine, which is the most common, particularly in adolescents and young adults, or tension headaches, which are pretty rare in early adolescence, but become more common in older adolescents and definitely more common in adults. The remaining group, which is anywhere from 8 to 28%, is a bunch of smaller things, some of which are concerning, some of which are not so concerning, okay? And these will all, we've talked a little bit about these already in the acute headache presentation. And then, of course, you can have also some psychological component. People with chronic pain may develop, sort of pain sensitivity, and they may sort of embellish the pain a little bit. But this is really, rarely is this the primary headache. And if you think it's primarily a conversion or somatoform, that's really a diagnosis of exclusion. You're really going to focus on the things that are most likely, or if you have the right symptoms that make you worried, you're going to focus on those things. Okay, so you can see here. So really, migraine and tension headaches are the vast majority. Almost 80% of these headaches fit into one of those two categories, and we've talked a little bit about how to diagnose them. The other ones, you'll have to do specific testing if you think, for example, there's an infection, if you think there's a brain tumor, although brain tumor, again, very small percentage here. So let's talk about the chronic headaches. Okay, so we already talked about how to diagnose migraine headaches, but we didn't talk so much about how to treat chronic migraines. So let's do that. And again, here's some interesting pictures from how children describe their headache pain and how you can see, how they visualize that. So again, so for migraine, it's a clinical diagnosis. You generally are not going to need imaging for chronic migraines. You do want to identify triggers, and if you can identify triggers, you try to avoid those. You do the headache diary, the stop therapy, the abortive therapy that we talked about already. In addition, for chronic migraines, you may need prevent therapy, headache therapy to stop them from having so frequent, especially if they're having migraines more than once a week. If they're having a bad migraine once a week that is debilitating them, maybe missing 1 or more days of school per week, usually you want to give a preventive medicine so they don't have so many headaches. It's also important to think about non-medication treatments if the headaches become chronic, because remember, there are many environmental triggers we talked about: stress, looking at computer screens, poor sleep, and so relaxation, biofeedback, stress management, mindfulness may also be very important in a situation for chronic migraine. If they get into chronic migraine where they're having frequent and severe migraine headaches, of course, this is where you would make a referral. Now, what kind of medicine? So you have somebody with migraines, you're going to give them medicine to treat the headaches when they flare up. But if they're having frequent headaches, and so they're missing, days of school every week, or they're missing work every week, you want to give them medicine to prevent headaches. So some of the first tier medicines for preventing headaches include amitriptyline, topiramate or valproate, butterbur and herbal medicine used to be included. There was some randomized control data, but it was kind of retired in 2015 because of some concerns about toxic byproducts. These have some indication for approved in adults, and we'll talk a little bit more about what the prevent medicines would look like in a child. But in young adults, you could go with these. The second tier medications include a whole new class of medications that have come out that work on the calcitonin gene-related peptide, what we call CGRP, and we'll go over those a little more in detail. This is a pain peptide that is tied to migraine, and you can block either the receptor or you can bind the peptide itself to prevent the pain signal from being transmitted. These are recently approved in the US and Europe and can be very effective, although they're usually not your first drug of choice. Other second-tier drugs include other tricyclics, beta blockers, although these have limited indication in people who have asthma or diabetes, other things like that. Gabapentin can be used sometime. Naproxen also can be used. And then third tier, there's some less popular beta blockers that don't have as good of data but may be helpful. Lisinopril has a little bit of data, verapamil possibly, carbamazepine. These are really your third tier. Again, when you get down to this level, really second and third tier, you're going to probably want to consult with your neurologist. But you could certainly think about some of the first tier medications in older teens or young adults who need migraine preventive medicine. Now, these new medicines that work on CGRP, these are the ones approved in the US, so they're all not available yet generically. The first 4 of them have indications to prevent migraine, and they are given as an injection usually. So these are all subcutaneous, one is intravenous. Some work on the receptor, some work on the peptide. But the interesting thing is that these doses are given and they can last. This effect will last for a month. Here's a larger dose, can last for up to 3 months. Here's an IV medication, again, approved to last for up to 3 months. So for patients with really chronic headaches who have not responded to other medicines, these newer medicines may be indicated. There are also a couple of CGRP medications that are approved to be given acutely in the acute phase of the headache, and these are listed here. Ubrogepant and rimagepant can both be administered. This is oral dosing, and this is an oral disintegrating tablet. These also have limits as to not to exceed 8 headaches per month with ubrogepant, and not to exceed 15 headaches per month with rimagepant. These are new medicines, so you may not have experienced them. This is more intended to see what will happen when the patients see the neurologist, but not so much for primary providers. Now, what about prevent medicines in kids? Well, remember, 2 of our big prevent medicines in older teens, young adults, and older adults are amitriptyline and topiramate. This study, we published in the New England Journal of Medicine just a couple years ago, compared amitriptyline, topiramate, and placebo for chronic pediatric migraine. And what they found was there was no difference in the primary outcome or headache disability. Here's the amitriptyline, topiramate, placebo, all look pretty identical. Okay, and so the implication was that maybe these medicines don't work as well in kids as they do in adults. And of course, the downside of giving one of those medicines is the active drugs had higher adverse events compared to placebo. So amitriptyline had more fatigue and dry mouth, and topiramate had more paresthesia and weight loss associated with it. So while those medicines are still used sometime in pediatrics, we use them less because of studies like this that suggest there's not much added benefit over placebo, and you have a greater risk for side effects. So when we think about preventive medicines in kids, we actually don't have any good randomized controlled trials of prevention medicines that are approved for kids. So the trend is to move toward medicines that may have some placebo effect, that there's some open label data that they might work, but are less likely to have the side effects of the prescription medicines. And so melatonin has been described in open label studies. Riboflavin or combination of riboflavin and magnesium have been effective, again, in uncontrolled studies. These may be effective. They also have a low side effect profile, so sometimes are preferred. You can still use tricyclics, but be aware of the study which I just showed you, which showed that you have a higher risk of side effects and not better than placebo. Same thing with topiramate. You can try other anticonvulsants. They don't have randomized controlled data, but valproate or gabapentin. Again, you might be able to use antihypertensive like propranolol. Older teens, you may try some of these adult medications. The downside for propranolol is obviously the beta blockade. So if the kid is an athlete or otherwise active, that may be a problem. Other things used are nonsteroidals and cyproheptadine. Now, very important for chronic migraine are non-pharmacologic interventions. Sometimes, even more important than the medications. Biofeedback, stress management, good sleep hygiene, and diagnose and treat if there are any underlying sleep problems. Make sure they're getting exercise, having regular physical activity, good nutrition. Don't overly restrict the diet. That's where you have to be careful with those triggers. You don't want to overly restrict the diet. And then, again, small kids aren't going to be using caffeine, but teenagers commonly now are going to Starbucks or other places drinking coffee. So you want to limit caffeine use in patients with chronic migraine. Now, another type of more chronic headache are the tension type headaches. These are rarer in small children, but more common in adolescents and then young adults. And it has a much different clinical presentation than migraine. It can be associated with neck or shoulder pain. You can have acute episodes that get better, or you can have kind of that sort of gradual, day in and day out headache that some days are worse, some days are better. You generally don't have nausea, vomiting, and you rarely would have photophobia and phonophobia. Once in a while, you may have one or the other, but typically these symptoms that we often associate with migraine are not seen in tension headache. You also usually don't have the pulsatile or throbbing headache. It's more pressure-like headache or band-like, frontal or occipital, bilateral. So these headaches sound much different and seem to feel much different than migraine, and so you can distinguish them clinically. Again, it's a clinical diagnosis. If they have the typical clinical features, a normal neurologic examination and normal optic discs, you don't typically need neuroimaging. You can do a headache diary, particularly for those with more chronic headaches. We focus a lot on non-pharmacological treatment that we talked about before, and including things like acupuncture or psychotherapy can help. Pharmacologic treatment, for episodic migraine, you can use analgesics or nonsteroidals. For chronic migraine, chronic tension headache, you can use preventive medicines, tricyclics or SNRIs. Be careful with chronic anti-inflammatories or chronic analgesics, and definitely steer away from opiates because you can get rebound or medication overuse headaches. When you get into the chronic tension headache, again, you may need a referral to your neurologist so you can deploy all of these types of treatment. Another type of chronic headache, it's not very common. You won't see it very much as a generalist, but there's some things that are interesting to know about it. Idiopathic intracranial hypertension, or sometimes called pseudotumor cerebri, is a situation where you have increased pressure in the brain without hydrocephalus and without a mass lesion. So they may have visual field problems. You may see papilledema. The workup would include ophthalmology, a lumbar puncture, some imaging, and you would look for a number of conditions that may be associated with this. Sinus thrombosis, being pregnant, some hormone problems, lupus, iron deficiency. You can see all listed here. Certain kind of medications have been associated with it, including vitamin A, often used like treating for acne in teenagers and things like that. Some antibiotics. If you diagnose this, and what you might obviously is you'll need a lumbar puncture and an opening pressure. If the opening pressure is elevated and the imaging shows no structural lesions, then you have a diagnosis. They can be treated. Sometimes just the lumbar puncture itself is therapeutic. If you remove as much CSF as you can, that alleviates the pain. Sometimes they need more than one LP. Also, you can use medications. Carbonic anhydrase inhibitors or diuretics, acetazolamide or furosemide have been used, sometimes corticosteroids. In severe cases with intractable headache, a lumboperitoneal shunt has been proposed. If you have severe cases and you have compromise of the vision, they can actually do optic nerve fenestration. Again, these are patients you will probably refer, but it's a different kind of intracranial pressure headache that is worth it to at least know about it. And the chronic daily headache, these almost always require referral. These may have both migraine or tension type features. These are not that common in small kids, but older teens and young adults, older adults can get these headache more than 15 days per month for over 1 to 6 months. So if they're just headache almost all the time, may have started as a migraine, may have started as a tension, but now it starts to kind of get somewhere in between. Rarely do you need neuroimaging. These people normally have normal neurologic examinations, unless you're getting symptoms of increased intracranial pressure. The pharmacologic treatments usually focus on preventive medicines, tricyclics, anticonvulsants, maybe other things. And really non-pharmacological treatments are important. Reassurance and education, they need to be reassured that it's not a tumor. Can they gradually return to activities? Is the headache should not prevent them from doing the things they want to do. They may need some cognitive behavioral therapy, and then relaxation, including acupuncture, biofeedback, mindfulness, yoga. All of those things can be helpful in these patients who have very frequent, very chronic headaches. Okay, so we're coming to the end. So headaches are really a common problem in kids and young adults. You can classify them by temporal course, by the acuity of the presentation, and by the type of head pain. And you can break them up into sort of migraine, tension, neuralgia, or increased intracranial pressure. Most acute headaches in young people are secondary to non-neurologic causes, so fever, sinusitis, concussion. Most subacute headaches in young people are actually primary neurological headaches like migraine or tension. So depending on where you're seeing the patient, you have different thoughts about the differential diagnosis. Migraine treatment, since migraine is the most common, you have 4 components. You avoid triggers. You want to educate the patient and family and reassure them. You want to give them stop medications to stop the headache when it happens. And if necessary, if they have chronic migraines or if they're very frequent, you want to give them preventive therapy too. And many headaches can initially be managed by the primary physician, and then you can refer the patients who have atypical headache symptoms or if they're unresponsive to the initial treatments. And so the final reminder is that everyone worries about a tumor, but this is what Arnold Schwarzenegger says.
I have a headache.
It might be a tumor.
It's not a tumor. It's not a tumor at all.
It's not a tumor. Thank you for your attention. I'm not able to hear you right now.
Sorry.
There we go.
Thank you so much. I think that one thing that I'm going to take home is the tip about drawing. I want kids draw, because in your practice, sometimes you just ask the parent and you can get to know what the children is actually feeling. That's a very good thing.
Yeah, that's a really good point. A lot of time parents will try to tell you what the headache feels like for their own child. And I've found that kids, even as young as 5 or 6, if you help them a little bit, can give you enough information about what the headache feels like that you can decide, does this sound like a migraine or some other kind of headache? And sometimes you have to tell the parent, hold it, ask them first, and then you can ask the parent too. Parents are very good for telling you how long the headaches might last or how frequently the child is complaining and whether or not the child has to stop doing things they want. Oh, I can tell when so-and-so has the headache because she stops playing and goes and lays down in a dark room. That can be helpful.
Well, Doctor, while our team is selecting the questions, we want to give a special recognition to our organization team, members of LAUGHH Foundation and Acome that work together every year to provide medical care and education to people living in towns with low income in Santander, Colombia. This year, overcoming the SARS-CoV pandemic, they have decided to keep on going with education and training to medical students and physicians around the world. Thank you so much. So the questions.
Yeah.
Are there genetic factors associated with migraine?
Okay, that's a good question. So, well, first of all, I want to say, again, thank you to you and the organizers and everybody who worked so hard to put this together. It's an amazing thing that you're doing, and you're really reaching out to, hundreds or more than 1,000 people all over the world. It's fantastic. So there are genetic factors associated with migraine. They're not very strong. So I mentioned the familial hemiplegic migraine, which is actually a genetic disease of which headache is part of it. That's the only one that's really closely linked to a particular gene. There are commonly family history of migraine in the mother or the father or maybe a grandparent, but you have to ask and find out the headache from the mother or from the father, does it sound like a migraine? It's usually not a single gene though, it's a polygenic relationship. So they have done very large genetic studies in cohorts with tens of thousands of patients, and they find each individual gene only contributes a little bit. But in the level of clinical care, asking if there's a family history can be very helpful.
Is there evidence that tendency for migraines is inherited or genetic?
Okay, so I think I'll just say yes. And again, like I said, probably it's more of a family history rather than a specific gene.
Besides medication, what other alternative therapies are there to treat headaches?
Okay, this is a great question because we always think as physicians that we have to write a prescription, right? But many times you don't. I think for an acute migraine, obviously you want to give them some medication for that. But they can also go to a dark room, go to a place that is quiet, try to sleep. And often, even when I prescribe medication, I tell them, in addition to taking the medication, go to a dark room, cover your eyes, be in a quiet place, try to sleep. If you're at school, you may have to go to the nurse to do that. And that helps the medication work better. For patients with chronic headaches or recurrent headaches, if you have chronic tension headaches or you have recurrent migraine headaches happening multiple times per month, then obviously you will use preventive medicine, but equal or maybe greater importance sometimes are the non-pharmacologic treatments that I listed on the slides. And so it depends a little bit on, for each person, what seems to trigger the headaches. But if stress is triggering the headaches, then psychotherapy or cognitive behavioral therapy or mindfulness, relaxation techniques can all help. Often headaches are made worse with sleep problems. So making sure that they have good sleep hygiene, that they're getting the proper amount of sleep at night. Some underlying sleep problems like obstructive sleep apnea, which are associated with hypoxia during sleep, actually have worse headaches during the day. So obviously you want to treat that. If they have, sort of lifestyle things in terms of if your blood sugar is low, if you are dehydrated, all of these things can cause headaches or can make existing headaches worse. You can make sure you eat proper meals, make sure you stay well hydrated, especially if you're out in the hot sun, and that will make it less likely. And then, of course, it's really important that aerobic exercise turns out to be a good treatment for many things, neurologic, but for sure, people who have chronic headaches or chronic pain, if you can do aerobic exercise, sometimes you hear about what we call the runner's high. The runners will run and they get into this place where they feel really good. That's actually biological. There's peptides made in your brain called endorphins, which are natural painkillers. So if I could have the choice to have natural painkillers from aerobic exercise versus having to take a painkiller, I think the natural painkiller would be better. So people who do aerobic exercise have the benefit of that, and they seem to have better blood flow in the brain and tend to have slightly easier to control headaches. So definitely all those things are very important.
Thank you. Is there a difference between lying or sitting position that makes a headache worse?
Okay, that's a good question. Not for many headaches, but there are some headaches that you would want to be aware of. So the one type of headache that can typically be very positional would be a headache related to intracranial pressure. So sometimes when people are upright, it may feel, and this would be low intracranial pressure. So there's a rare type of headache with low intracranial pressure. When you sit upright and then there's gravity, it tends to pull on the pain-sensitive structures in the brain. I would say if you have a highly positional headache, you probably need to do a very careful neurological exam and then maybe refer them to the neurologist, because these are a little trickier to make the diagnosis. The other one, which is very common, would be the type of headache that occurs after lumbar puncture. So if you do lumbar puncture to rule out meningitis in somebody, or maybe you do lumbar puncture to rule out the idiopathic intracranial hypertension, often after the lumbar puncture, the CSF will still leak a little bit. And then when that person sits up, they will often have a very bad headache. So then after lumbar puncture, you usually have them lay down for several hours. You make sure they stay well hydrated and things like that.
Does dehydration also plays a role in migraine onset? Sorry.
Okay, good question. Does dehydration play a role in migraine onset? It may. I don't know of any studies that confirm this, but we do know, I see a lot of young patients in my clinic, and quite a lot of them are athletes. And so patients who are recovering from an injury, who haven't been doing their usual fitness, and then they go back very quickly. If they get dehydrated, or if they aren't eating regular meals, and then the added exertion of going back to physical activity can sometimes trigger migraines or headaches that sound like migraines. People who are dehydrated who don't have migraines can also have pretty bad headaches. So it probably contributes, but there isn't any studies I know of that directly connect it.
When a headache should be treated in a hospital?
Okay. So, well, not too often, right? I mean, people will come to the hospital when they have a severe new onset headache. And those headaches, like I said, either come to the hospital or come to urgent care, and they need a proper evaluation at that time. Okay. Then it really depends. If they have meningitis, well, obviously then they need to be in a hospital setting to have the treatment for that, right? If they have intracranial bleed, that needs to be treated in the hospital. If they have migraine, that's a little different. Most migraines don't need to be treated in the hospital unless the nausea and the vomiting is so severe that they can't stay well hydrated. Then you can't really send them home. There are also rare situation, again, which probably would not be seen very often by a primary doctor, but we call status migrainosis. Somebody with a migraine has gotten so bad that it's just going continuously. They can't eat, they have a hard time sleeping, they come to the hospital. In those cases, then you do need a neurologic consultation, and there are some intravenous medicines that can be given to sort of break the migraine headache. Often you also give antiemetics, you give hydration. Some people use opiates, although again, most cases of status migrainosis I've successfully been able to treat without using opiates. We try to avoid those in the treatment of migraine.
Are there any specific red flags on headache for children?
Yes, absolutely. If you go back to my third or fourth slide that says worrisome headaches or common headaches, and the worrisome is underlined, the red flags are the symptoms for focal neurological problems. So weakness, visual field cut, things like that, having a focal seizure, signs of elevated intracranial pressure, so nausea and vomiting, particularly that gets worse in the middle of the night. Now that will overlap a little bit with migraine, so you have to be careful, right? But nausea, vomiting, if you can see the optic disc, if they have papilledema or swollen optic disc, these are all red flags that tell you this person almost certainly needs imaging and may need additional testing. The other thing is if they have headaches and they have mental status change or they have fever, you better be thinking about infection. And again, that may require imaging, that may require lumbar puncture. And then if they have meningitis or encephalitis, obviously they're not going to go home, you're going to treat them.
Is any of this medication contraindicated in
lupus patients? Yes.
Patients, yes.
Yeah. Well, sure. I mean, there's so many medications that I listed there. I think it's hard to say specifically. lupus patients who can have headaches for different reasons that aren't necessarily migraine, right? So I think if you have a lupus patient who has headache, the first thing you have to do is figure out, is the headache due to lupus? Is it due to migraine? Lupus patients can have vasculitis. Lupus patients are often treated with corticosteroids or immunosuppressive medications, so they may be at risk for opportunistic infection. So I think before you even think about, I'm using a migraine medicine on a lupus patient, if the lupus patient is having a headache, you have to do a differential diagnosis and figure out what the headache is. If I was comfortable in a lupus patient who was stable, who also had migraines, then it would depend again on if they have focal neurologic symptoms with the migraine or not. Typically, I would use the milder type of migraine medicines. I would probably steer away from migraine medicines that would change blood flow. So I would probably be cautious with the triptans and cautious with the blood pressure medicines in those patients.
Should we try mindfulness or music therapy? Any other non-pharmacologic procedures? Thank you so much. It was an excellent conference. Writing from Bolivia.
From Bolivia. I visited Bolivia in 1999. Beautiful country. Had a great visit there. Absolutely. For chronic pain of any kind, particularly chronic headache, and particularly in kids, it's helpful to find ways to change their pain threshold that don't involve chronic use of medications. And so relaxation training, mindfulness, teenage kids can do biofeedback. Some people like acupuncture. Some kids really hate the idea of getting little acupuncture needles, but some kids, if it works for them, they prefer that to taking the medication. Music therapy is not as well proven, but I think there's no downside, right? So if you can use music, and even if it just distracts them from the pain, that's probably helpful. And then again, other non-pharmacologic things we talked about, make sure good sleep, good eating and hydration habits, regular exercise, also very important.
Will most patients still need abortive medication for acute migraine after the prophylactic treatment?
Okay, excellent point, and I didn't specifically address this. They may. So the abortive treatment is when the headache breaks through. So if you give prophylactic treatment, what will happen is the severity and the frequency of the headaches will be diminished, but there's no prophylactic treatment that's 100% effective. So even if I am taking, topiramate or amitriptyline or melatonin or whatever it is I'm taking to prevent my headaches, once in a while, I may still have a migraine on top of that. So it is important for them to have an abortive or rescue medicine for when that happens. But for most kids, that abortive medicine might be acetaminophen or ibuprofen. If it works for them normally, then they can still have that. I have many chronic migraineurs who are on preventive medicine, and then they have a rizatriptan orally disintegrating tablet they carry in their purse, or the school nurse has it. And so if they do have a breakthrough at school or at work, they can take something right away and go lay down in a quiet place to try to control the headache. But good prophylactic treatment will actually mean they won't have to use the abortive medicine as much.
Okay, thank you, doctor. That was the last question.
Okay.
Thank you so much for being here, and we hope to have you in more events.
Okay, well, great. Well, I wish you great success on the other sessions that you have coming up. It was really fun being able to join all of you and continue the good work.
Thank you.
All right. Bye-bye.
Bye. We're going to explain again how to get the certification. You must be registered. If you're not registered, in the description box, there is a form to register. Then at the end of every day session, our team will enable an attendance form that is going to be open for an hour, and it includes a keyword that will be displayed on the screen during the conferences. Finally, you must have attended at least 7 out of 9 days to get your certification. This concludes our second day of conferences. Thank you so much for your participation and patience, and remember to fill the form. See you next week.
Mi nombre es María Camila Velasco, tengo 25 años, soy médica de la Universidad Javeriana de Bogotá, hice el MIR 2020 por primera vez y obtuve un puesto de 583 en la lista definitiva. Quiero hacer anestesiología en el Hospital Clínic de Barcelona. Para mi preparación escogí CTO en la modalidad virtual, me preparé desde Bogotá. Estudiaba en la biblioteca y en la casa. Mi curso comenzó más o menos en febrero y estudiaba más o menos 10 horas al día. Escogí CTO porque era el que me daba la posibilidad de hacer la modalidad virtual, porque sabía que tenían experiencia con la plataforma y porque llevan muchos años preparando estudiantes para el MIR. Lo que más me gustó de la preparación fueron los simulacros. Pienso que fue un punto fuerte de CTO en esta convocatoria porque al hacerlos tan difíciles no estuvieron preparados para lo peor y creo que en mi caso me funcionó mucho. Para la gente que se está preparando en estos momentos, sobre todo para los extracomunitarios y a los colombianos, quiero decirles que uno puede lograr el objetivo. Lo más importante es la salud mental, hacerle caso a la academia cuando hay que descansar, las semanas de vacaciones que le dan a uno, tomárselas como son, sin hacer trampa y sin estudiar en esos días. Pienso que es muy lograble si uno se lo propone. Así que mucha suerte en la preparación, espero que les vaya muy bien.
En Focus encontramos una posibilidad diferente a otros programas de educación en inglés de una segunda lengua y es basada en un aprendizaje de la experiencia, donde da unas facilidades rápidas en cuanto a la adquisición del speaking, la capacidad de hablar, y el listening, la capacidad de entender cuando escucho, sí, fortaleciendo su componente gramatical. Hoy por hoy todos hemos estudiado inglés en cierto porcentaje y esto lo que busca es desarrollarlo, y los que no pues pueden también empezar poco a poco. Y también una flexibilidad horaria y de educación continua a nivel virtual, que es un potencial que hoy también es la vanguardia mundial, estudiar y capacitarse a nivel virtual, con una experiencia real personal. No es un curso netamente virtual, no es un curso netamente presencial, sino combina las dos estrategias que son efectivas en la educación. Y por eso es una muy buena oportunidad y experiencia que hemos visto que colegas lo han tomado. De hecho, el convenio fue por sugerencia de los mismos miembros del Colegio Médico. Y por eso queremos invitarlos a que lo tomen.